can the respiratory system compensate for acid-base disorders? Well, the lungs can only compensate if it is a metabolic disorder. If the lungs themselves are damaged or have disease, they can't compensate. They are going to be the problem. So if it is a respiratory problem, the lungs cannot compensate. Now, how can they compensate for metabolic acidosis? Well, the respiratory system can cause hyperventilation, increased rate and depth, blow out more CO2. That reflects a loss of acid, and your pH will come back up to normal. If you have metabolic alkalosis, we see that the ventilation rate and depth will decrease. That reflects trapping more CO2. The trapping of CO2 will help lower the pH back down to normal. Have you heard of Kussmaul breathing? Maybe no. Kussmaul breathing is really hyperventilation, and we see that in a diabetic patient, a patient with uncontrolled diabetes mellitus. A patient with diabetes mellitus is most certainly going to go into metabolic acidosis. Why? They are using fats as fuel, and I just explained to you, their body, like ours after sleeping, is in a post-absorptive state. You will actually see a patient hyperventilating who has uncontrolled diabetes mellitus. This type of breathing is the same type that I'm referring to as hyperventilation, but we just call it Kussmaul breathing. This is just a handy-dandy little chart putting together in a different way everything I've been trying to tell you. What is acidosis? It is too low pH. How can you have that problem? Too much acid or too little base. Alkalosis is too high of a pH. How can you have that problem? Too little acid or too much base. If, for these conditions, the acid is the problem, the CO2, then it is a respiratory issue. Only the kidneys can compensate. If, however, bicarbonate is the issue, the base is the issue, and then we say it is a metabolic disorder. Both, then, the respiratory and kidneys can compensate, but the respiratory compensation is much faster than the renal compensation. I am giving you some reasons that a person can have respiratory acidosis or alkalosis. Again, your job is to remember normal values for CO2. It is 35 to 45 millimeters of mercury. What can cause respiratory acidosis? An elevated CO2 greater than 45 millimeters of mercury. What if a person has had brain trauma or their respiratory center in their medulla oblongata has been compromised, say due to an overdose of narcotics or too much anesthesia? That would be anesthesia. That can depress the breathing center, and that means trapped CO2 and less ventilation. We also can have a problem with respiratory muscles. How about curare? If someone were exposed to curare and their diaphragm could not contract, then that means we would not be able to get volume changes in the lung to get pressure changes to cause gases to move in and out of the lungs. What about myasthenia gravis, where the person is losing nicotinic acetylcholine receptors, and now their diaphragm cannot bind acetylcholine as much? We also can see this with lung diseases like emphysema and pneumonia, where you get a lot of CO2 trapping. What about respiratory alkalosis? This is a loss of CO2 lower than 35 millimeters of mercury. Hyperventilation syndrome, psychological fear or pain. Someone who sees something horrific starts to take really deep breaths in and out. That is hyperventilation. What if a patient is on a ventilator and it is on too high of a setting? When you go up to high altitudes, there is less oxygen pressure and there is also less CO2. So more CO2 comes out of your lungs with every breath. Fever can also cause hyperventilation. So those are some ways that you can have elevated loss of CO2, and that means low CO2 in your blood. What about metabolic disorders? How can a patient have metabolic acidosis or metabolic alkalosis? I will remind you that normal values of bicarbonate are 22 to 26 milliequivalents per liter. Let's do metabolic acidosis. How can a person have that? They can ingest too many foods that are acidic. I always tease my physiology students after every exam not to go into, quote, metabolic acidosis by drinking too much after the test. Carbonic anhydrase inhibitors. This is one type of a diuretic. If abused, they can lead to decreased hydrogen secretion in the kidneys. Aspirin overdose. Again, you're ingesting an acid. Diarrhea. Now, diarrhea is interesting. Diarrhea is a reflection of intestinal movement. We think of very runny feces. Well, diarrhea means increased gut motility, but you are also losing all of your enzymes, and you are losing your pancreatic buffers. The pancreas, like the red blood cell, has carbonic anhydrase, and that means that the pancreas is capable of producing bicarbonate. So if you are having diarrhea, think of all of your bicarbonate buffer being lost. If you are losing your base and you are retaining your acids, that is going to lead to metabolic acidosis. Accumulation of lactic acid, say during a severe diabetic ketoacidosis, too much of a post-absorbed state, or starvation, all of that will lead to metabolic acidosis. What about metabolic alkalosis, where we have levels of bicarbonate higher than 26 milliequivalents? Well, a person can eat more bases, just like they can eat more acids. We see this in leisure world syndrome, where the elderly take a lot of antacids, like Tums. I call it blue hair syndrome personally. We also see metabolic alkalosis if our kidneys are going through renal failure and are not reabsorbing the acids. So excessive loss of acids can lead to metabolic alkalosis. Gastric vomiting. If you were to vomit your stomach contents, that is a loss of acid. If you are vomiting your hydrochloric acid from your stomach, but you are keeping your bases, that means you have metabolic alkalosis. Other diuretics can cause metabolic alkalosis. Other diuretics meaning anything but carbonic anhydrase inhibitors. Potassium depletion can also cause metabolic alkalosis. I will remind you that if a person is in hypo-K, there will be a cellular shift of potassium out of the cell in an effort to compensate for that hypo-K. But that means that there will be a shift of hydrogen into the cells, and the person will have metabolic alkalosis. How can a person have hypo-K? From increased aldosterone through Conn's disease, for example, or a person who is on steroid therapy, like mineralocorticoid excess. Again, it's all about aldosterone excess. It is the same thing. So what is the problem with acidosis? I am showing this here on slide 27. The problem with acidosis is actually the effect of the increased acids causes central nervous system depression, meaning that there is decreased synaptic transmission. If you stop and think about skeletal muscle, we recognize that skeletal muscle needs synaptic transmission, right? We need somatic motor neurons releasing acetylcholine on the skeletal muscle in order for it to have an action potential and then have a contraction. A person with acidosis is going to have muscle weakness. In general, they are going to have deranged central nervous system function. They will have disorientation. They can go into coma, and this will most certainly lead to death. I remember watching this show called I Shouldn't Be Alive. In one episode, there was a really bad tropical storm, and a group of people, they were on this yacht-type luxury boat, and the boat sank. They got into a dinghy, and they were floating in the ocean for days. A couple of the men got to a point where they got so dehydrated and starving and had such bad acidosis, they started hallucinating. They were so disoriented, they thought they could see land. They jumped out of the boat, and they didn't realize that there were a bunch of sharks around them at that point. Both of them were torn to bits by blue sharks that had been following the boat. So, severe disorientation can occur from acidosis. Well, what can we expect to see in a patient with alkalosis? With alkalosis, you are going to have overexcitability of the central nervous system and peripheral nervous system. This means neurons are going to be firing acetylcholine onto muscle, and we are going to see muscle spasms and tetany and convulsions from this overexcitability of the central nervous system. They will have numbness, paresthesias, abnormal sensations, because the sensory neurons are also firing randomly. They will also have lightheadedness. Again, they can lose consciousness, and death can result from alkalosis as well. So let's wrap up what you've learned. A simple way to approach any acid-base disorder. You always need to know your norms. That is your job as future care providers. You need to know step 1. If your patient has a pH lower than normal, that means acidosis. If it is higher than normal, that means alkalosis. Step 2. If you determine that they have acidosis, your step 2 is to remind yourself that that can happen from too much acid, CO2, or too little base, too little bicarbonate. If it is acid that is the problem, it is respiratory acidosis. If the base is the problem, then it is metabolic acidosis. Step 3. You have to ask yourself, how will the patient compensate? Well, if they have a base problem, then they are going to compensate with CO2. If they have a CO2 problem, then they are going to compensate with a base. If their pH is too high, we can do the same thing. We can have alkalosis by too much base or too little acid. If it's too much base, that is the problem, then it is metabolic, and the correction is going to be focusing on CO2. If they had too little acid, then it is a respiratory alkalosis problem, and the patient is going to try and compensate with the bicarbonate levels. Now I would like to tell you about the anion gap, because this is also another important concept to think about. If we are talking about the electrolytes in blood plasma, they should balance each other, meaning we should have equal values of charges. In a clinical laboratory, we don't measure all of the electrolytes, or lights as they say in a clinical setting. It is slang. We look at the ones that are the biggest contributors. Out of all the cations, sodium is by far the most abundant. That means that all of the positive charges of sodium should be matched by negative charges from anions. The two biggest contributors for negative charges are chloride and bicarbonate. The remaining missing negative charges is going to be from other negatively charged anions, which are too numerous to measure independently. We just group the others into one big group called the anion gap. You're seeing that in the left column here, where I say that it is electroneutral. This means that the positive charges from sodium are being balanced by the negative charges from chloride, plus the negative charges from bicarbonate, plus all of the remaining anions. We can actually use the anion gap to help predict what type of acidosis a patient is in. Up at the top of the screen on this slide, I am saying the other negatively charged substances are proteins, phosphates, citrates, and sulfates, etc. There are too many of them to measure independently. Therefore, we just group them together. Look at my middle problem here. You will notice that my chloride levels have shifted from the initial electroneutral state. Chloride levels have gone up. You are also seeing that bicarbonate levels have decreased. But the amount of the anion gap is still the same. Now you need to be warned. A lot of times, clinically, they will say that there is, quote, no anion gap. When you hear that, you need to think that there isn't, or you're tending to think that there isn't an anion gap. Really, what they mean is that there is no anion gap change. Make sure you mentally correct what they are saying in your head. There is still an anion gap, but what they mean to say is no change. When they say no anion gap, it means no change. When we see that a person is in acidosis, but the anion gap has not changed, and we know it is metabolic acidosis, that lack of anion gap change will help us reduce the possibilities. Likely the person has diarrhea. They have lost their bicarbonate because of all the fecal material being washed out of the system is carrying away all the bicarbonate buffer. The anion gap, the proteins, the phosphates, the citrates, the sulfates, those values have not changed because of the diarrhea. This problem could also be due to renal acidosis, where the kidneys are not reabsorbing the bicarbonate as well as they should. But what about metabolic acidosis, where there is a larger anion gap? You will notice that the chloride levels are the same as before. Look at the far right-hand picture. But bicarbonate levels are lower than normal, and there is a greater anion gap. That tells you that the person has more negatively charged substances, more acids that have come into their body. How can that happen? How can a person have metabolic acidosis where the anion gap gets bigger? Ketoacidosis from uncontrolled diabetes mellitus. That is number one. Salicylic acid ingestion, which means taking too much aspirin. Or lactate from maybe the person has had a lot of muscle damage. Chronic renal failure can also lead to this. But uncontrolled diabetes mellitus, that is a number one reason for anion gap increase. A patient can have metabolic alkalosis not only from having Crohn's disease, but from abuse of diuretics. Diuretics work in several different ways. Let's start with the left side of this problem. A patient who is abusing their diuretic is having excessive urine production, and this reflects a decrease in extracellular volume. So you agree that urine is basically a derivative of blood plasma. More urine output reflects loss of plasma volume. Loss of plasma volume you will learn in class, will lead to the release of the angiotensin pathway. This leads to an increase in angiotensin II production. Angiotensin II can directly lead to the release of aldosterone. Let's back up a bit. A patient is overusing their diuretic. They are peeing too much. This means their blood volume is going down. Decreased blood volume means GFR is also going down. A decrease of GFR will lead to the release of the renin-angiotensin pathway, ultimately leading to more angiotensin II synthesis, where angiotensin II means we have more aldosterone secretion, and more aldosterone secretion means we will have more sodium and water reabsorption, coming at the price of more potassium secretion. More potassium secretion means potassium levels in the blood plasma are dropping. More potassium secretion by the distal convoluted tubule cells also means that we have increased tubular hydrogen secretion at the same time. More hydrogen secretion by the distal convoluted tubule cells means that we have synthesized new bicarbonate. More bicarbonate production means more bicarbonate in the blood plasma. Elevated bicarbonate levels will tip the scales into metabolic alkalosis. Crohn's disease is excessive aldosterone release. What is going to happen with that excessive aldosterone? We are going to have potassium depletion. Potassium depletion means that we are going to have more potassium going out of the cells, and we are going to have that hydrogen shift, where hydrogen will go more into the cells. This potassium depletion in the tissues is going to be exacerbated by the kidneys. When the kidneys are reabsorbing more sodium because of the aldosterone, they secrete the potassium. When they do that, some of the cells in the nephron also secrete hydrogen, and this leads to more tubular hydrogen secretion. We are going to have a double whammy here. Not only are we going to have hypo-K, but we are also going to have alkalosis because of the cellular shift in tissues for potassium and hydrogen, but also renal secretion of hydrogen. That is going to lead to increased bicarbonate reabsorption and new bicarbonate production as a result of this excessive aldosterone. This will lead to metabolic alkalosis. In slide 32, I just want to remind you of this cellular shift. What if we have hyper-K? In this picture, I am reminding you that if we have hyperkalemia, then that means that we will have more potassium shifting into the cells. As a result, hydrogen, to maintain charge exchange, will be released from the cells of the body. This is going to lead to the acidosis along with the hyperkalemia. When a person has hyper-K, they can actually give the person insulin, which will further increase the potassium shifting from the blood into the cells, which will help lower the potassium in the blood. But this is going to exacerbate the metabolic acidosis. It will lead to more metabolic acidosis. You might be thinking that both of these conditions are not the best. Remember, normal values of potassium are supposed to be between 3 and 5 milliequivalents. Just a small change of potassium, going from 5 to 6, can stop a person's heart. The metabolic acidosis is the better trade-off than the hyperkalemia. That is part of the reason why they will give insulin, because insulin stimulates the sodium-potassium ATPase. So that pump will bring in more potassium. Again, this can lower the blood values of potassium back down to the normal limits. This concludes our discussion on acid-base balance.